So my name is Jonathan Schwartz. I'm a structural interventional cardiologist at Sanger Heart and Vascular Institute in Wake Forest University, Charlotte, North Carolina. Today we'll be just discussing updates on tricuspid valve interventions. There's been some important recent advances in tricuspid valve therapies, particularly this year. As we get more and more data, we're learning more about the procedure and which patients benefit the most. At TCT, we saw two recent trials that were presented. One was real-world updates on the EVOQUE device from the TVT registry database. It sort of reaffirmed some of the findings that we've been seeing, but it's nice to be able to replicate those in real-world populations as opposed to just the trial with the strict criteria that patients must meet to be enrolled there. But it proved that the device is very safe and effective and also can be used in patients with electronic implantable devices. Very similarly, the tricuspid clip, the TriClip device, the updates from the TriLuminate study were presented, which included data from all of the roll-in patients as well as the continued access patients. So it was the largest population to date that was presented. It reaffirmed the efficacy and the safety of that device as well. So both devices are quite safe and quite effective. They each sort of have their nuances as to which does best in certain types of patients. And valve replacement obviously is a bit more complicated than putting a repair device in. And so the safety is very good in both, but it is the mortality rates are slightly lower in the TriClip population. But the efficacy, if you go strictly based on TR reduction, basically the EVOQUE device completely eliminates TR. The TriClip device is about an 83% of patients get at least moderate or less TR. There's a lot of debate still about what level of residual TR is acceptable, what should we be aiming for. I think in general, everyone likes to shoot for mild or less, but clinically, it does seem to appear that just a reduction of at least 2 grades of TR seems to be effective. And so in that regard, both devices are quite effective for patients. Yeah, so that's been a bit of a hot topic. So the benefits of the device primarily have been symptomatic at this point. And there's a lot of controversy about, are we assessing that properly with KCCQ scores? Is maybe there a better way to do that? Is some of the benefit we're seeing, is it due to placebo effect? I think in speaking with my colleagues that also do this procedure, we can all say it's very evident that patients do get quite a bit of symptomatic benefit from this. We have not seen mortality benefit yet. I think part of that is there's still a lot of work to be done about which patients are the best populations to be studied for this and which ones will benefit the most. And I think as we get more long-term data and more experience with the device, we'll probably learn more there. There has been shown a reduction in heart failure hospitalization at the 2-year mark in the TriLuminate data. And then there's trends toward mortality benefit and heart failure hospitalizations with the TriSend EVOQUE device, but we just don't have statistical significance there yet. So I think more to learn, but it's promising. Oh, this is always a tough question. So which patients benefit the most? I think number one, they have to be symptomatic. Clearly, the most benefits shown here have been those patients that are symptomatic. And so those that have refractory edema or really severe dyspnea on exertion, then they're limited quite a lot by their symptoms. They tend to show the most benefit. In the same breath, they have to have at least a decent quality of life at baseline. You know, if it's someone who is not very functional, you're not going to get a lot of benefit from doing a procedure in those types of patients. And then I think the last one is some assessment of the right heart function. Those patients that have very poor RV function don't tend to do very well with this. How we assess that is still, we're learning that. I think the TriLuminate study did have an imaging sub-study that showed quite a bit of benefit in RV remodeling after the procedure. And so being able to sort of determine which patients have that reserve that can improve afterwards is quite important. There's also some early data that shows various ways of measuring RV function. One in particular is the PAPI number. Patients that have very poor numbers with that don't tend to do very well with tricuspid valve intervention. So a combination of functional, very symptomatic, and good RV function. Great question. So deciding between repair and replacement can be difficult. I think somewhat it is dependent on the expertise of the institution. those institutions that have a lot of experience with MitraClip, I think, very easily transition to tricuspid clip. They are quite different procedures, but the overall, the maneuvers, the imaging, the setup of the room, everything is pretty similar. The EVOQUE was a new procedure for all of us to learn, but it's not too different from what we're used to. So some of it plays a role in that. I think anatomy very largely drives this. You have to have a coaptation gap that is suitable for the TriClip device to be able to grasp both the leaflets, although we have learned that that is somewhat malleable and can be adjusted with optimizing the patient, maybe admitting them a few days ahead of time and diuresing them quite a bit. You can very largely decrease coaptation gaps and make patients candidates that weren't before. Whether they have a implantable electronic device, again, a lot of debate about, is it okay to jail those leads or not? Can you navigate around them with a clip device versus do you need to extract them? Does your center have expertise in that? And then also, lastly, reimbursement can't be ignored. I think the economics of the procedure is somewhat regional and depends on which institution is doing it and where you work. And so I think all those things have to be considered in addition to your usual heart team meetings with these patients. So these are both very complex procedures. I think getting as much training as you can ahead of time is key. And we're all still learning. So yes, there's people that have a lot of experience in this, but I think we would all admit that there's still a lot to learn. So it's a combination of don't just assume that it's very similar to mitral interventions. It's quite different there. The imaging is quite more difficult. So having a good relationship with a structural heart dedicated imager really is key for success there. And then I think patient selection, as we discussed earlier, making sure these patients are functional, symptomatic, and their RV function is suitable for something like this where they will actually show benefit. So reaching out to the experts, I think we all love helping each other, so we can learn together.